It is a fairly common complaint. Typically what happens is someone has a sensation of some retrosternal, meaning behind the sternum, behind the chest wall, of burning or typically a burning type of pain that's going up the chest. You know, at some point in their lives, most people have probably experienced heartburn, and really what it's caused by is reflux of gastric contents back up into the esophagus. There's physiologic reflux, which is normal, and then there's pathologic reflux. The vast majority, a large proportion of the population has physiologic reflux, where they have some reflux, meaning a backwards flow of gastric contents, stomach contents into the esophagus after meals. It really becomes pathologic, meaning a disease for people, when it starts to happen frequently and they start to experience symptoms of it. Typically what happens is someone will have a meal and then maybe 15 minutes later they'll start to have that symptom of heartburn. Other times they'll lay down to go to bed at night and then they'll have symptoms when they lay down flat. Typically that's caused by gastroesophageal reflux disease. That's what we call that. This person that has heartburn maybe once a month, that's probably what you would consider pretty mild disease. But when it starts to affect their quality of life and they have severe heartburn, you know, multiple times a day after every single meal, that's when you really want to take a closer look at it. When we say GERD, we're talking about GERD, written out G-E-R-D, stands for gastroesophageal reflux disease. That can be a clinical diagnosis when someone comes in with typical heartburn symptoms. Not everybody comes in that way. Other people may not have any heartburn, but they may have other symptoms, things that we may call alarm symptoms. An example of those symptoms would be coughing, wheezing, dysphagia, difficulty swallowing, weight loss, throwing up blood. And those all can be signs that there may be something more ominous going on the inside. And those are the patients that we like to take a closer look at and make sure that their symptoms are attributable to reflux and not some other more serious concerning condition. Gastroesophageal reflux disease can be associated with long-term complications. Some of those long-term complications are esophagitis, inflammatory changes in the distal esophagus, Barrett's esophagus, where the cells change from one type to another from chronic reflux disease, strictures, which is a narrowing in the distal part of the esophagus, which can cause difficulty with swallowing, cancer, which is obviously the most serious and most dreaded complication of long-term reflux disease if it's untreated. Other complications can be chronic exacerbation of asthma as well. The symptoms of heartburn can be confused for other issues in diagnoses. Certainly anybody who has chest pain, we are concerned about a cardiac origin. Are they having a myocardial infarction or what we call a heart attack? And you really want to rule out a heart attack, certainly as people get older if they're having these symptoms for the first time. Once those are ruled out, then we typically pursue a path looking for reflux disease. We usually start with a consultation. Really what we want to hear is the history from the patient, the history of when did my symptoms start, how frequent are they occurring, and specifically what are those symptoms they're having. Some of the more atypical symptoms that people present with gastroesophageal reflux would be hoarseness, coughing, kind of diffuse chest pain. Certainly we want to rule out a cardiac origin in those cases. They can go to their dentist and the dentist may ask them about erosion of the enamel, and that can be a first clue for some people that they have pretty severe heartburn, gastroesophageal reflux disease causing decay of their teeth. So when people come in, the first thing we want to do is take a history and we examine their symptoms. If they don't have any concerning symptoms, it's reasonable to start medical therapy as a first-line treatment. Medical therapy being medications like antacids or anti-secretory medications to decrease the production of stomach acid to theoretically decrease the severity of gastroesophageal reflux disease. Certain people don't fit into that category. They may have more severe symptoms. They may have late onset of symptoms in life where we want to rule out another concerning finding like an esophageal stricture or cancer or peptic ulcer disease. The tools that we have to evaluate for gastroesophageal reflux disease and other problems in the upper GI tract are an EGD. An EGD stands for esophagogastroduodenoscopy. It's similar to a colonoscopy, but we're going in from the top, putting a scope in someone's mouth, going through their esophagus, into the stomach, and into the first part of the small intestine called the duodenum. We blow that up with air, and then we take a look at the wall and make sure that there's nothing concerning on the inside. People with long-standing gastroesophageal reflux disease can get changes of their distal esophagus, something called Barrett's esophagus, and that can put them at an increased risk of esophageal cancer. So that would be another reason to do an EGD on those patients that have had gastroesophageal reflux disease over maybe 5 to 10 years. Another population that would benefit from an EGD is patients who have severe reflux disease that's refractory to medications. Not everybody responds to the medications that we usually treat them with. Those are people that we like to take a closer look and make sure that there's nothing else concerning going on the inside. They may have severe esophagitis, a stricture, hiatal hernia, peptic ulcer disease, or even a cancer at times. We can also do a swallow study where we have a patient swallow contrast and take an x-ray. That can be helpful to really delineate the anatomy and look at the function of the esophagus to make sure that it's working properly. A third test that we have is called pH monitoring, where we can put a probe down someone's esophagus and have them and track them for about 24 or 48 hours and really see how much acid is getting back up into their esophagus. That can be a key to really determine if there's further intervention that may benefit those people. The pH monitoring can be very helpful because it can give you a score to determine how severe their reflux is. In addition, you can correlate their symptoms with when they're having reflux. They can press a button and then you can correlate and see if they actually had a lot of acid in their esophagus during that time period. Those people that have a good correlation of their symptoms with reflux episode, those are people that can be considered for anti-reflux surgery if medications are not treating their symptoms effectively. Some people don't respond to the initial treatments for gastroesophageal reflux disease, which would be medical therapy. Alternatives include switching to a different type of medicine, a different class of medicine, or pursuing a further workup with an EGD to make sure that there isn't something else concerning going on the inside. Not everybody responds to medications. Certain people respond to one type of medication over another, and in a subset don't respond at all. And those are people that we consider for further workup and evaluation to see if a surgery would be a surgery like a Nissen fundoplication would be something that would benefit them in terms of their reflux disease. Those are people that we would typically perform an EGD on, as well as pH monitoring to make sure that those symptoms that they're having are attributable to reflux disease. A lot of times patients are very frustrated with reflux disease and heartburn, and they may not have good symptom relief. But the important thing to remember is that in addition to medications, we have other interventions that we can do to pursue a definitive diagnosis and come up with a treatment plan for patients. So if the medications are not relieving all of their symptoms, we have more options for them in the future. And it's important for them not to give up and to remember that, because we're here to help them.